All right, doctor. So I'm just gonna start admitting anybody who shows up. Bring them in, or did you want to wait until the 8 o'clock?
You can bring them in. We'll start in about 5 minutes. Just
Okay.
people start trickling in.
Okay.
Yay. Okay, so Gabby just joined.
Wonderful. Okay. Trios.
Recording in progress.
So turn down the mic. Just mute yourself. Yeah. And turn off the microphone too.
Hey, Gabby.
Thanks for being. You're here for technical support. Yes, sir.
How do I turn off the mic?
This there should be a mute. Or he can mute you too.
No, just mute it. Right there. Perfect.
Let me just turn off.
That's the mute. Yep.
All right, so the main monitor is off over here. She's our audio speakers.
You're
Huh?
waiting.
I explained it to her twice.
I don't think she understands that. Actually, I don't think he's on a patient.
Okay.
She's very odd person.
Oh, she,
Yeah, she's just
She's gonna get the doctor in here. I said, he's busy, I'm sorry. You know, the C2, so I gotta go.
and then they could sit by tonight.
What?
I know by 5. I did earlier.
Go to the gym. After this.
You only went twice today?
I went last night.
You should record an email at General. Did you record?
I forgot. Friday, Saturday, Sunday, I do 2 weeks.
Well, because that's when you go.
I go with my wife in the morning. Maybe my son go in the evening.
You go to JV3?
Then I go to Crunch, it's like the closest one to me.
He goes, there's this alley down by his house. He's got some spare dumbbells. He works out in the alley with the homies.
With the hood homies. Hood rat hookup.
Well, I was pissed off because you said you went to get a haircut, but clearly you did not.
I just tapered the side.
He made it sound like a big deal. He's like, Doc, you gotta go get a haircut. It's the only time my barber is available. It's like urgent. I'm like, dude, like this guy needs a haircut bad. I know how that feels. And he comes back and all I do is trim his eyebrows.
They shaved them off.
They're thin already as it is.
Like that doesn't count as an urgent
Wait,
haircut.
doctor was
Hmm.
my model,
Your mom?
the teeth models. Didn't they make them?
No.
Oh.
Because Christina was out today.
Mhm.
So we're just gonna talk about other cases. Did she get her test?
So you don't need them?
We're gonna still demo
Oh, okay.
the scans, the face scans.
Wait, are you getting a case or are you doing
Okay.
All right, doctor. So we got about a minute left before we touch the 5 o'clock hour Pacific time. Did you want to start on time, waiting for people to trickle in? How do you want to do this?
We can start on time. It's recorded, right?
Yes, it is.
Okay, so if people miss the beginning and they want to go back and watch, they can.
Yes. Did I ever tell you that I do some stand-up comedy?
You'd be good at it. You have a face I could laugh at.
Thank you. Don't know how to take that, but okay, I'll take it. But the reason why I bring that up is that sometimes, we feel like, oh, you have to start on time because honestly, or that's how you keep the audience honest.
Okay. I could see you on stage.
Really, I've been doing it for some years.
You got a good persona.
You know,
Are you like an angry comic or like a political?
no. Self-deprecating. I always
Oh,
like
okay.
the kind of bring you home with me type, kind of like a Joe Coy, only with a Puerto Rican spin.
Okay. I like Joe
But
Coy.
tonight you're the star.
I won't tell any jokes because now I'm second
Oh,
fiddle. You're
yeah, I don't
funnier.
know. I think you'd fare well.
I have actually always dreamed about doing comedy. Like if I had a talent other than dentistry, it would either be a chef, I love to cook, or like a stand-up comedian. I have so much respect for
Really?
stand-up comedians. You know, I consider them the modern philosopher. Like the
Yeah.
Socrates, like in ancient Greece, you had philosophers who would stand up and philosophize, and they would talk about spirituality or life or biology, whatever. We don't have that anymore because everything's written in textbook. But comedians are our modern day philosophers. They tell us about life. They make us laugh and make us think about the world we live in, just like a philosopher does.
I love it. I love it. Smiles all day. All right, so we are at 8:01. Let's go ahead and begin. Everybody who's already here, thank you so much for joining us. Ray America with Dr. Ryan Dunlop, CBCT Planning for Advanced Full Arch Implant Cases. Doctor, I know that you wanted to do something along the lines here of like a real world setting, show everybody what you go through when you go through one of your cases. You're also going to show us a couple of other cases after you do the real world setting. I'm excited to see it. Floor is yours.
Great, thank you. These are really fun to do. We had a busy day today, but it's nice to end the day with kind of some education, some community outreach, and tell people out there who are listening about some of the fun things that we are doing. Some fun things that we are doing with the Ray Face hardware and the Ray Team software, the CBCT, the intraoral scans. So if you guys are listening, you can mute yourself, or Mario, maybe you can mute some people. But I'm going to go ahead and share my screen here, and so we can go through some slides. Great. So you guys can probably see my screen now, I think. I'm going to play a slideshow. Okay, so we're going to talk about the Full Arch Masters digital method and how we use the Ray Face software and the Ray Team software to enhance predictability on our full arch reconstruction patients. Just to review a little bit, if you tuned into my last webinar, we went through kind of the process in detail. So I'm not going to go through the entire process again. Mario and the team at Ray America have a link to that webinar. So if you guys want to learn about the Full Arch Masters method in detail, you can go back and refer to that webinar. The basic process that we teach at our courses and the process that I use in my clinics is kind of a soup to nuts A to Z philosophy on full arch dentistry. So it all starts with the branding and the marketing, drawing new patients in and being able to put forward a kind of uniform message from your front office through to your clinical, all the way through to the lab, and then the hygiene afterwards. You have to have a very well-built team in order to do this. As you will see in our live demonstration today, I'm going to be talking and narrating, but my two assistants, Gabby and Jackie, are going to be here showing this methodology. And I even have Jose, my media guy, kind of lurking behind, making sure everything's running. So even in this small microcosm of full arch dentistry world, I have a team helping me right now. So it takes a village in order to get full arch dentistry done at a high level with great predictability and precision. You also have to have the right equipment. We'll do a quick review on what equipment is necessary to do these types of cases in your clinic, in your labs every single day. There has to be a consultation and a closing process that has to be well trained. You have to have a treatment coordinating team, a sales team that is educating your patients, motivating them, and getting them to sign up for treatment in your office. Otherwise, you're only going to do 1 to 2 cases at a time. And really the investment and the time and the education it takes to get good at this is really not worth it if you're just doing 1 case at a time. You need to be able to scale your business, scale your practice, and do 10, 15, 20, 30, 40, 50 of these cases at once. And you cannot do that with the right planning and the right systems. The pre-op planning is essential. That's what we're going through today. And how to acquire the right
digital data for your laboratory and for your clinic to be able to deliver stellar results. Surgical intervention is necessary for all these cases. Implants don't install themselves, so you have to open a flap, you have to place dental implants, you have to have accurate imaging through your CBCT so you can have a great plan. Whether that's a guided methodology or a freehand methodology doesn't really matter as long as you are entering in with a plan. You have to know how to manage complications in your cases, both immediate complications such as surgical, which can involve bleeding, pain, infection, paresthesia, swelling, all those things, but then also long-term complications such as implant bone loss, prosthetic failures, implant failures. So we teach a good methodology for how to do that. There's the long-term prosthetics, which is after healing. So patients go through a surgery or preps and they end up with temporaries. And you've got to transition those patients from their temporary restorations to their long-term restorations. And then following up with the long-term follow-up, the hygiene care, the branding and getting patient testimonials from beginning all the way through to end and then beyond. And then being a true leader for your team, being able to be the hardest working one that is guiding and leading the team and not just a boss who's calling orders from his or her office. So that's kind of a snapshot of what the Full Arch Masters methodology really is. It is putting together all of these puzzle pieces in your career to form a cohesive unit that is Full Arch Masters methodology. I mentioned the equipment. The equipment to be able to do this level of work is substantial, but it's all very necessary. Each one of these pieces of digital equipment on the clinical side and the laboratory side completely eliminates a problem that you will have if you're not digital. So if you are not digital and you're doing these cases analog with wax try-ins and verification jigs and mounted models, you're going to have so many pain points along the process, just like I did 10 years ago, that you're going to burn out and you're not going to be able to scale your practice. Your patients are going to be frustrated. The lab's going to be frustrated. You're going to be frustrated. Everyone's going to be frustrated, and you're not going to enjoy this type of work. This list or menu of digital equipment, one by one, eliminates all of those pain points. So a digital camera will eliminate the pain points associated with an iPhone photo or a Polaroid photo or something, low quality. A facial scanner like the RayFace will eliminate the limitations and the pain points associated with photography. Then you've got your intraoral scanners, your photogrammetry scanners. These are all better than impressions, right? So impressions with impression material is the lowest quality data we can obtain, and intraoral scanning and photogrammetry scanners, that's the highest quality data we can obtain. And of course, you're going to need motors and handpieces and surgical instruments and implants and abutments and all kinds of stuff in your inventory, in your armamentarium for your surgical and your prosthetic visits. On the lab side, you ideally need to have a computer station that can do designing. If you're not doing designing in-house with your clinic, you can outsource that design. There's literally hundreds or thousands of designers all over the world that can do this kind of work. You need to have scanners. So if you're going to scan dentures or you're going to scan models, you need to have a desktop scanner. You have to have a 3D printer because if you're designing in-house or you're outsourcing that, you need to have a way to manufacture same-day teeth for patients. We don't do denture conversions. We don't do pickups in the mouth. This is all designed digitally. If you want to transition to an in-house lab manufacturing scenario, you need to have milling machines, furnaces, ovens, bench area to finish cases aesthetically. And so you can see the menu is pretty extensive for the type of stuff you need, but each one of these things effectively eliminates a pain point along the process. So if you can go from CBCT and facial scanners and intraoral scanners at the data acquisition side, all the way through to cam and milling and furnaces and ovens to make these final prosthetics, you can have complete control over the process from A to Z. And your patients will feel the difference, you will feel the difference, and your team will truly be empowered to help you deliver the highest quality, most predictable outcomes. Oops. So this is just an overview of the different stages in the Full Arch Masters workflow. The first stage is our pre-op. Before we've ever laid hands on the patient surgically, We haven't changed anything. All we're doing is capturing data, right? So this is where we set up the cases. This is where we establish the bite dimension, the vertical dimension, and this is where we're taking photos and facial scans. So we're going to kind of demonstrate how easy it is to do a good preoperative workup in a matter of minutes today. Surgery, we're not going to show that. I'm sure Jackie's happy to hear that. We won't be taking any teeth out today. We won't be installing any implants, but that's part of the process. And so, we teach that as well. And then after patients have healed, they go from a temporary prosthetic to a long-term prosthetic, and that can mean a lot of different things in terms of materials, but there's a separate process to take patients from pre-op to surgical as there is to go from healed to long-term restorations. So this is kind of where this is as good as it could get in terms of the planning before the implementation of the RayFace 3D software. We used to do a lot of cases like this. We would take photos as best we could. We would take intraoral scans as best we could, and then we would align those photos to the intraoral scans. And then that would allow our designers to design the case before we ever lay hands on the patient. So this works. Like this is not a bad workflow. But when you dive into this a little bit deeper and you start using 3D facial scans, you immediately see that even on the same patients, you have so much more control and predictability over what your desired outcome is going to be before you ever do it. There's not as much guesswork when you are incorporating this high resolution 3D facial scanning from RayFace and matching that to either your CBCT data if you want to, or to your intraoral scan data if you want to. But you can really build this digital avatar of your patient without having to have them in your clinic. And now you can do all of your prep work when they're not here, which greatly enhances the accuracy and the predictability. Here's another case of a young man with really bombed out dentition, serious overbite. And you can see with the implementation of the 3D facial scanning from the pre-op, this is not like a post-op scan. This is all designed for him before we ever lay hands on the patient. So I can establish a vertical dimension. I can plan about the amount of bone reduction. I can plan where the implants need to be. I can predict the access hole position. I can widen his smile or make it narrower. There's so much more I can do with the cases before I ever do a non-reversible surgical intervention by using this type of technology. So through, my courses, I always teach garbage in and garbage out. So through a really repeatable and precise methodology for data acquisition and planning at the beginning of your case, you will have a more predictable, higher quality outcome at the end of your case. And that's really the goal. There's so much that goes in to these cases. You have to have so much training and knowledge in surgery and prosthetics and occlusion that the last thing you want is unpredictability, right? You want to be able to know that if you are providing this service for patients and they're, trusting you and dedicating their life savings or their credit to you and giving themselves up to your trust, you want to know that unpredictability is not one of the factors you have to deal with. Yeah, if there's a complication, obviously you have to know how to deal with it, but complications happen, pain happens, bleeding happens, broken teeth happen. These things are going to happen. They're out of your control, but predictability should be in your control. You should be able to know that if you follow the recipe from A to Z, that you're going to get a predictable outcome from a predictable method. And that's why Full Arch Masters is so popular, is because we teach you and your team how to have a predictable outcome with a predictable method and not have to reinvent the wheel every time you do this. Okay, so that means we're going to now transition. I think we're going to switch to the other camera. Actually, you guys can see the intraoral scan right here, but it's going to show up on that computer, right?
Yeah.
So I'm going to stop sharing my screen, Mario. And you can still hear me, right?
Yes, I can.
Okay, good. So now I'm going to share this screen. Oh wait, this is the trios, right? I'm gonna share it. I want to share. No, we're not on Zoom there.
No.
So I'm gonna share a script. This screen. We'll show the 3D scanning from this one. So now we're gonna show the Trios 3D scanning for how we like to capture the records, and then we'll do the ray face to show you guys how easy that is. Okay. So my two assistants, Jackie and Gabby, are here, and we're gonna just go through how quick and easy it is to get these intraoral scans, and then I'm gonna show you guys kind of how we have established the vertical dimension so that we can get the right bite for our reconstructive cases. So you want to go ahead and start the scanning. So we use the Trio system here in the clinic. It's pretty much, in my opinion, one of the top intraoral scanners. Certainly for the full arch digital workflow, it's a great scanner for pre-op. It's a great scanner for surgical and for post-op. So you can see now we're scanning her lower teeth. It only takes a few seconds to get the scan. So we're treating Jackie as if she was going to have a reconstruction. So she's either going to have a crown and bridge reconstruction, she's going to have an implant reconstruction or a veneer reconstruction. But it's the same workflow for any type of dental procedure, whether you're doing dentures or you're doing crown and bridge or you're doing implant restorations. It all starts with the same diagnostic workup, which is to scan both arches in occlusion. And then the last step is to establish the ideal bite relationship between the arches. So she's just about finished with the lower jaw here. When we do these scans, you can probably see on the computer here, we want these to be full coverage digital scans. Okay, so we want to get as much gingiva, we want to get as much vestibule, certainly all of the teeth. We want these to have as much data as we possibly can, because if we're going to change things dramatically, we need to have a clear picture of each one of the arches. So she's done with the lower. She's going to lean Jackie back just a little bit, and she's going to scan the upper. So she's going to dry off the teeth just a little bit. You guys can see this a little bit, right? As I narrate, at least on the computer. Yeah.
We can make out the arch.
Yeah, exactly. Hopefully everybody watching has seen an intraoral scan before. But just to show how quickly it's done. Oh, you want me to? Oh, look at you. Okay. So now we're going to scan the upper jaw. Now, when we scan upper jaw for pre-op for full arch, we need to make sure that we scan all of the teeth, obviously. We want to get the full palate. Sometimes we get scans from clinics where they've skipped the palate, but that's an essential part of the reconstruction. So Gabby's going to scan all the teeth. She's going to rock and roll from the buccal to the palatal and get all the occlusion, the incisal edges. And then she's also going to scan the full palate and try and get the vestibules and the tuberosities. Again, we always want to have the most coverage and exposure on our digital scans. It's easy for the lab technicians to cut away data that they don't need, but it's very hard or impossible for them to add data that's not there. So when you're doing these scans, always, always, always overscan rather than underscan. So she's got the teeth pretty nicely. Now she's scanning Jackie's palate. And once she's going to wrap around and make sure that she has as much of the vestibules as possible. Again, these new generation scanners are very, very fast and very, very good at getting soft tissue and hard tissue, provided that it's not mobile. So if it's like mucosa and it's moving around, it's probably not going to scan it that well. But if it's attached gingiva, teeth, or palate, it's going to scan it in seconds here. Okay, so that means now we have an upper scan and a lower scan, but we still don't have the relationship between the upper and lower jaw. If we wanted to restore her at her current bite, we would just scan the bite as is. So let's just show how easy that is. So if we were happy with Jackie's bite position and her vertical dimension was fine, then we would just scan the right side and the left side, and the AI component of the software is just going to capture that bite and lock the upper and lower jaw in. So we're going to show how quick and easy that is if the patient's occlusion is where you want it. So within a couple of seconds here, there's the lower, there's the upper, boom, the AI component of the software found it. While the patient's still biting down, Gabby's going to scan the other side, and it's probably going to pick it up in just a matter of seconds. There you go. So now we have an accurate bite position for Jackie's reconstruction if we were happy with this bite. Well, we're going to do something else. We're going to delete this bite, delete both bites, break open these models again, and then I'm going to show you exactly the process that I go through as the doctor planning the case. Is I'm going to evaluate Jackie's vertical dimension, and we're going to scan her at an open bite position as if we were opening her case, opening her bite. So my favorite little tool to use for this type of work is a video gauge. You can get these online. They're pretty easy to find. It basically has two measurements on it. You've got a straight measurement and a curved measurement. And the two numbers are the same, but they represent two different measurements. The first measurement is from the lateral canthus of the eye to the commissure of the lip at rest, in occlusion. So the first measurement is a static measurement that shouldn't change on the patient's face over time, from the corner of the eye to the corner of the mouth. The second measurement is from the base of the nose or the anterior nasal spine to the chin. And this measurement represents a variability. So as somebody loses vertical dimension over time, this number is going to get smaller, but this number should stay the same. So when you're measuring patients for full arch or full mouth reconstruction, this is a very, very handy tool because it turns out that about 80 to 90% of people have the same measurement here. So you can have a more predictable result if you're setting your vertical dimensions using a tool like this. So if I measure on Jackie's face and I measure from the corner of her eye to the corner of the lip, I get about, let's say, 70 millimeters. So 70 seems to be about the normal measurement for most people. Obviously, if they're very tall, they'll have a bigger measurement. If they have a very small face, they're going to have a smaller measurement. But 70 is a good kind of average that I have found. So if I measure 70 millimeters from the corner of her eye to the corner of the mouth when she's in occlusion, then I switch that around and I measure from the base of her nose to the bottom of her chin like that. I can see sometimes that it's a perfect match, or I can see sometimes that there's a deficiency and there's a little space underneath the hook of the chin. And if there's a little space underneath this part, then I know that the lower third from the nose to the chin is deficient in comparison to the measurement of the eye to the corner of the mouth. And so then you can start to decide, how much do I want to open the bite on a case like this? How much do I want to increase the vertical dimension? And the way that we do that is with a second little tool called a leaf gauge. So a leaf gauge is a series of thin plastic tabs that represents increasing vertical dimension, right? So if you take a certain amount of them, let's say this is 25, and you have the patient bite down in the front of their mouth on 25 tabs, you're opening the bite by that amount, okay? So if I have Jackie bite down on 25 tabs and she tries to close down on her back teeth, I have her kind of protrude. So push your jaw all the way out and pull it back, protrude, and then go all the way back. By the second or third time, the patient kind of seats their condyles into the retruded position and gets to a repeatable position. So what I like to do with my patients is that I have them bite down on this leaf gauge for a few minutes, 45 seconds to a minute. What that's doing is it's putting pressure on the jaw joint at that position, and I can tell if they're going to have joint problems. So if they start to have pain in their jaw joint or pain somewhere, that's probably not a position I want to put them in for long-term restoration. So it's very helpful to go through this diagnostic pathway and make sure that you're loading patients at the vertical dimension that they can sustain. If you ignore this process, you're going to have a certain number of patients who come back with jaw pain after you restore them, and that is incredibly hard to fix. So why not just test it from the beginning and establish if that's going to be the right position. If the patients get pain from biting on the front of their teeth, right, you can take like a blue bite, and you can have them hold this anterior position, take your bite registration material and squirt that into the back of the mouth where the teeth are occluding. Then you can pull that out and have them rest on the bite registration material and hold that bite for another minute and see if they have pain. So again, a very, very helpful diagnostic strategy for testing VDO and making sure that you can and should do the restoration at that point. Let's assume that after a minute, Jackie says, yeah, this feels great. My muscles don't hurt. My jaw doesn't hurt. I love this jaw position for myself. I'm just going to take my intraoral scanner, go to the bite again. And while she stays motionless, I'm going to scan the right side and the left side. Well, my scanner wakes up here. So now I'm scanning in an open bite position. And you can see on the monitor that the same thing happened as I did before, but now the arches are separated. So I got the left side, I got the right side bite. And then lastly, I'm going to do the left side bite. And so it pulled in the upper model and the lower model very, very quickly. And now on my screen, there's two models floating in space that are not touching. Okay, so they're kind of floating above each other, and that represents the same space. So now that she has the bite registration done in the computer, we now need to do facial imaging, but we want to do it at this vertical dimension. We don't want to have her close down again because that will slightly change the length of her face. So I'm going to take my bite registration material, like I just said, and I'm going to put this bite registration material in between the posterior teeth, like the molars and the premolars, on both sides. Okay, so I did the right side, now I'm doing the left side. And what this is doing is it's replacing the leaf gauge in the front of her mouth with the bite registration that we have in the back of her mouth. So once this is fully set, I can wiggle out my my leaf gauge and will maintain the vertical dimension that we've established by measuring with the VDO gauge and capturing with the leaf gauge. Sorry, that's a mouthful. So this is probably almost done here. So now I'm going to just wiggle this out. So I now took the leaf gauge out, but because I locked her bite in with these splints in the back of her mouth, she's now at the vertical dimension that we want. And I don't have this thing in the way. And now we can transition her to taking the ray face. And now I think I'll stop. Now I think we'll share this screen. Is it on that one or this one? So go to Zoom and go share screen. Yeah, share. And then do screen. So hit share. Yep. Okay, so now you guys should be seeing the Rayface computer, right, Mario?
We are.
Okay, great. So can we put this? So you stay there. And move this. Yeah. Okay, so Jackie's now going to come across to the Rayface. We're going to walk through the data acquisition process for scanning. Now, remember, I put bite registration behind her, or in between her posterior teeth. So she's held open at that vertical that we want. So that's why we put that bite registration material in there, because we don't want to have that leaf gauge in the way when we take our face scans. So we want to have a clear view of the teeth so that we can align it to our intraoral scans later. So Gabby's going to walk through how quick and easy it is for us to get these facial scans using the Rayface. Okay. Yeah.
Okay, so I'm gonna have you put your hair behind your ears, all the way back. And then there are different cameras on here, but your main focus is gonna be right here. I'm gonna have you sitting up nice and straight.
So Jackie's sitting up straight and she's facing forward and she's gonna look right at that dot that's in the center of the ray face scanner.
And just a hair, I'm gonna have you move in.
And Gabby's guiding her how to align her face so that she's in proper alignment for the scan.
Okay, the first one that we're gonna capture is gonna be a test run, no smiling. Okay, perfect. Now this one right here is going to be your regular smile.
So we do a series of ray face images. We do a natural repose, which is what we just did. And now we're going to do what we call like our portrait smile. So now Jackie's going to give us kind of her driver's license smile, the normal one you would take for a photo.
And scooch in just a hair. Right there. And then same smile, ready, 1, 2, 3. I'm gonna take a series of photos. I'm gonna take one more at this position, hold it. Perfect. So the next photo that we're gonna be taking is gonna be an exaggerated smile. Smile as big as you can, but make sure you maintain that bite. Ready? 1, 2, 3, big, big, big. Hold that position. I'm gonna take one more. Perfect. Go ahead and relax.
So you can see that we went from kind of natural repose to portrait smile to exaggerated or forced smile. So kind of increasing the intensity and the energy output that it requires to do it. And the reason for this is a lot of your reconstruction patients, they don't like smiling, they hate smiling, and they certainly don't like smiling big. So getting them to do this is sometimes a challenge. And you'll see in some of my cases that we present next that patients don't want to smile. So if you start with just kind of a natural repose, and then you go to a portrait smile, and then you do the forced smile, you'll get a pretty good outcome that way. And you want to take more than one scan. You don't just want to do one smile. You want to give your laboratory as much information as possible, whether it's repose, it's a regular smile, or forced smile. That's going to give them the most data to create the most predictable response, especially if you're doing cases like FP3 with bone reduction or crown lengthening cases. You need to really be able to show that full smile and the natural smile and compare the two. So now what we're doing is we also like to do ray face scans with a retractor. An Optrogate seems to work the best. And the reason we're doing this is we want to have the maximum best alignment for our intraoral scans to our face scans. And a retracted view gives us the best outcome for that. So while she's still biting down, she hasn't kind of opened and changed her vertical. We snuck in an Optrogate in there. And now we're going to take another series of ray face scans so that the lab can better align the intraoral scan to the face scan. And this works extremely well for patients who don't have really good anatomy on their teeth, or they're missing a bunch of teeth. Sometimes you have to align off of premolars and lower incisors and, you know, worn down broken canines. So you really need to have the best view of the teeth so that you can align correctly.
Okay, we're gonna take the retracted photo, switch back just a little bit. And then scoot in just a hair right there. Our lips are not gonna be green like they were before because she doesn't have any, so we're just gonna take that retracted one and it's okay. And then go ahead and look straight ahead. There you go. And I'm gonna have you hold that position.
Good. So you can see we're taking multiple images. There's really no downside to having multiple images because you may get a better image off of one than another. And it's really not a lot of time here. It's not like this is a 2-minute scan. This is 2 seconds. So it doesn't hurt us to take multiple scans. Sounds good? Okay. All right, Mario. So now we're going to do the whole cooking show thing, and you're going to magically produce all of her aligned records, right?
Yes.
So what we did, just for those who are listening and watching, we did this last week and as a practice, and I sent Mario the scan so that you guys can see what all these scans look like put back together. And that usually takes how long would you say, Mario? About 10 minutes to align all these different data sets.
Well, the
So
alignment takes seconds. It's the
yeah,
adjustments and anything that you're trying to do. I would say somebody who's pretty proficient could 5 to 10 minutes do a
right.
quick walkthrough with a patient.
Right. But my point is, you don't have to have the patient stay in your chair while you do that, because you capture the data and then you can send them on their way, and all of that work can be done afterwards.
Absolutely.
So, all right, you want to go ahead and share your screen then?
Yes, sir. Let me know if you can see it.
Yep.
Okay, so yes, this is the information that you sent, and everything is up here in the upper region of the software. Let's get that there. So you see all of your stages here. Now,
Wait a
go ahead,
second.
doctor.
I'm not seeing anything yet. Oh, there it is. Yeah, it needed to load, I think.
Okay.
Yeah, we're good
All
now.
right. So did you want to walk them through, doctor, or should I just
No, you do
this?
it. Yeah, walk through kind of toggling on and off the different layers and some of the analysis features of the software.
Okay, so thank you, doctor. This is our patient here. And just to take one step back, just to show you where you're able to introduce your data, here's where you have your pictures that were taken with the ray face. Then also you have your intraoral scans, the bite registration, and then your CT. Very important to have that there. And then from there, we can, give me a second, guys. All right, I wanted to kind of get this guy out of my way. So right here in the upper right-hand corner, we have that smile arrow, and that'll take us into the software. So right here, we have our first stage, which is aligning all of our facial scans. We can go through them here. So again, it takes minutes. We're doing here pretty much analytical, taking a look at what we have here and then going forward, making sure that everything is pretty much aligned. Here, again, the AI takes over, gives you your intraoral scan, both of them together in occlusion, and then matched up with your CT. We could take that out. And then this one was taken with a bite stick. And that also shows there. Then we can go forward and we see that our facial scan has also been introduced, and we have all of our data adjusters here on our right side. So we're able to kind of transition anything in and out just to kind of see what we want to see. Also, if we wanted to check any accuracy, we have the ability to go to our cross section. Cross section will allow you to kind of come here and grab your planes. So you have your sagittal going across, showing your slice explorer. Then we have our horizontal, which will take us from up top from our facial scan down to the intraoral scan, hugging our CT scans. Once we have that situated, we're able to come here and see how it aligns with our intraoral scan as well. If we felt we did not have the proper alignment that we wanted, we have our keys over here to be able to adjust. And then also the ability for our point placement to be able to adjust. Next stage, we have our digital face bow. So basically, we're able to take our patient and check their planes. So from here to the tragus, taking into account our Frankfurt, we have our occlusal plane, campers, and we're able to turn on and off those planes if in case we wanted to see anything in particular. Next stage would be pretty much our kind of like home stretch, if you would. Basically, this is where if you were going to send to your lab, like you sent to me, we would come to a button here, send through the Ray Teams. Or we can come here to our apps and be able to do a smile design, which is what I was able to do here. We can take this. We have our library. I don't know if you guys can see this from just a moment. I want to move this over here to this side. We have our library here. And basically what we can do is just change our patient's smile. And also what we can do is we can do some wow factor as well as some patient education. So we can come here, do a side by side, be able to show the patient where they were with that initial smile that we took with our ray face, and then show what can be. And alluding to what you were explaining before with our patients that don't have much dentition, that would be a night and day comparison. Then we have the ability to come here for export. And then here you have two abilities. If you have an in-house lab, such as yourself, you'd be able to do any designing yourself, or you could export, send that out to your lab. And then we have all of our integrations here, which would be able to open it up to another software. After you're done there and you're done with your smile design, you can also look at some other things. If your patient has some ailments, they don't know what's happening, we want to take a deeper dive, we can have our Slice Explorer take a look. And this is where your CBCT and your ray face work in tandem. So not only do you have the ability to see the Slice Explorer, but now you have your patient's face. So now it's a personal conversation. And also the seeing is believing. They see where that ailment is. They're able to identify that. You can take that into a deeper dive and really explain some things to your patient. And then finally, with the ray face being included, you'd be able to take this patient, go to the beginning after we've made all of our alignments, we're ready to go. We also want to share this with our patient because our patient is our partner. We'd be able to come to the beginning here after our smile design. This button down here is a QR code. So we come here, we go to our Ray Teams, we're able to check off the boxes, let the software kind of pull this up. And what we're able to do is create a QR code where the patient would be able to scan the QR code, doesn't need to install a software, but they'd be able to take their digital avatar with them on their phone. You can also add your office logo, and that is what they will take with them when they're showing friends and family on what they're able to, what you're able to do for them, and how their treatment plan is going to be able to go. So that's some of the features with the software that, you know, is capable of being done. And not only you being able to treat your patient, but them feeling like they are a part of it. It just makes all the difference of, you know, the compliance within the treatment planning.
Beautiful. Amazing.
All right. I'm going to share this back with you, doctor, if that'd be all right.
Yeah, I'll take over.
Thank you so much.
So I will go back to my presentation here. Okay, I think you guys can see my screen again. So everything that Mario just went through, first of all, amazing technology, Mario. You guys have really pioneered and perfected that this workflow. I'm going to walk through how I use this same exact workflow on some of my real cases. This is a patient, Richard, that we did upper and lower reconstruction. You can see on the left side, he has a ray face exactly the same way that I just did it. He has blue bite showing, which means I opened his bite. I did the vertical dimension analysis, injected blue bite after capturing the open bite with my intraoral scanner, and then did ray face at that desired vertical dimension. In the middle, you can see the digital wax up based off of the pre-op scans that we took. And my lab is able to replicate and duplicate this design into what you can see on the right side here, which is an immediate load prosthetic that is anchored to 4 dental implants on top and 4 dental implants on the bottom. So again, going from a pre-op evaluation and diagnosis to a solid digital plan before surgery, and then carrying that exact plan forward to a surgical intervention without having to do any bite scans or any denture conversions. We're just designing, 3D printing, and installing. No assembly required. Here's another case that I did recently. This was more of an FP1 case. So if you know the difference between FP1, FP2, and FP3, FP1 cases are basically tooth-only restorations. So they're implant supported restorations, but they're screwed down and only replacing teeth. There's no gum tissue on these restorations. So patients love them because they feel more natural. Dentists love them because they are sleeker and thinner and nicer, more biocompatible restorations, but they require even more treatment planning, less margin of error, and more prone to complications. So this type of work excels using only this workflow. You want to have a predictable methodology that yields predictable results, because these surgeries are hard. These surgeries are time consuming, and you don't want unpredictability to be a factor. So you can see on the left side, the pre-op situation with some crown and bridge that was falling apart. She's missing a bunch of posterior teeth, and she wants to transition to FP1 prosthetics. You can see in the middle here, this is our design and wax up. So from the vertical dimension that we scanned her at, we then do the full mouth reconstruction wax up, and then you can see on the right that we now have that exact same wax up, but now it's attached to 6 implants on the upper jaw and 6 implants on the lower jaw without ever having to pick up an analog technique. This is all a seamless digital workflow. And so both of these patients have these teeth in their mouth right now. These are finished cases. Here's another gentleman that we did the exact same protocol on. This patient had a big underbite, class 3 relationship. You can see from the pre-op, he looks kind of grizzly. He got big lower jaw. He doesn't have a lot of upper teeth to align off of. So the same workflow where we do a vertical dimension analysis, then we do an intraoral scan at that vertical that's desired. Then we do ray face and planning, as you can see in the middle here. This is the design off of the intraoral scans and the face scans at the vertical dimension we want. And then you can see on the right, that same exact design where we're now able to correct his jaw relationship and put him more in an edge-to-edge or in a class 1-like relationship from an underbite to proper occlusion in one visit. So he now has these upper and lower implant-supported bridges on 4 to 6 implants, upper and lower. Again, taking the design to the reality. Another case that was just done recently for an upper and lower FP1. Again, vertical dimension, you can see on the left side, I evaluated her vertical dimension using the same technique I just showed you, and you can see the blue bite in her mouth, so I opened her bite a little bit. I used the leaf gauge, I had her bite down, I locked the bite in with a splint on either side, and then I'm able to remove the leaf gauge and capture these beautiful images and transition to the second phase, which is the planning phase. So you can see in the middle is our 3-dimensional plan. And then on the right, you can see the outcome of the plan into reality attached to 6 implants on the upper and 6 implants on the lower. So how do you get good at this stuff? Well, you buy all the equipment and you call Mario and you say, I want a ray face and I want a ray scan, and I want an intraoral scanner. But there's a piece missing, and that's the education, the clinical and the laboratory education. If you're going to try and do this stuff, education is the backbone to success. And Full Arch Masters is the backbone of education in full arch dentistry. So we provide education on the clinical skills, the laboratory skills, and the administrative skills as well. It's all one big happy family. The FAM Education Continuum is anchored by our flagship course. That is our main course. It's a 4-day course that we run 4 to 5 times throughout the year. We're going to teach you and your team about digital workflow, laboratory footprint, sales training, marketing and branding, evaluating cases for medical considerations. We're going to demonstrate live surgery on real patients to show you how easy it can be. And then we're going to put you in simulated environments that are safe and predictable for you to practice and learn how to do this workflow yourself with your team. After you go through the flagship course, we want you to take our surgical course. Our surgical course, we have one next week in Parker, Colorado. We run these courses 2 times a year, and they are massive. We have 25 or 30 doctors there. We have 10 surgeons going at the same time. We have anesthesia in every room. People are doing regular all-on-X, tilted implants straight, advanced all-on-X with pterygoids and zygomatics. Every room is a different case, and it goes for 3 or 4 days straight. So that's like Disney World for full arch dentistry. You get to work one-on-one with our mentors, and we load every case. Okay, so this is where you've taken the flagship course and you are now ready to go put it into action. The third leg to the wheel is we're going to do a laboratory. We do laboratory courses twice a year as well. So if you want to get into designing, you want to get into aesthetic finishing for full arch cases, our technicians guide you through the process of designing cases, printing cases, milling cases, and making them look beautiful. And so that's another 4-day course that we offer throughout the year. And then we have a variety of other courses. We have sales boot camp. We have, anything under the sun that's for full arch related, we do. And we teach this specific workflow on real patients, and you guys get to do it on our patients here at Better Life Dentistry and Full Arch Masters. So if you're interested in learning more about the courses, they always sell out because they're very popular and we train at a very high level. Check us out at fullarchmasters.com. Or you can email us at info@fullarchmasters.com. And I advise everybody to go online on Facebook, follow Full Arch Masters on Facebook and Instagram. And I have a private group that anybody can join that we post cases and educational content every single day on these Facebook pages and Instagram pages. So follow us, ask questions. You can see in my picture here, I'm toasting you. I hope you enjoyed this presentation. Mario, thank you very much. Jackie and Gabby, thank you for staying after today. If you guys have any immediate questions, we're here.
I did have one, doctor. We discussed the ray face, and that's definitely a component of and a useful one in the workflow that you're presenting here. How do you go about selecting what kind of CBCT you're looking for? What kind of criteria do you look for when you're choosing a CBCT?
Well, I just choose ray face. I mean,
Oh,
I just choose ray scan.
fantastic.
No, the reason I chose ray scan is because the clarity of the image is outstanding. The alignability and the workability inside the Ray Team software to be able to bring your CBCT in as easily as you showed. I do all of my surgeries freehand. I'm not a guided surgeon. I have utmost respect for guided surgeons, but it's not me. So I use my CBCT very, very in depth to plan my surgery based on anatomical landmarks. So if I don't have scatter reduction, if I don't have a quick loading software, if I don't have clarity in my images, and if I don't have the right field of view, that CBCT is useless to me. I'm not relying on a guide. I'm relying on my brain to guide my implant placement. So what do I need in a CT scanner? I need a ray scan. The ray scan, it has scatter reduction. It has very easy files to load. The softwares that work with the planning are excellent, and it integrates with the Ray Team's software so well that I can have a seamless planning strategy for these cases.
That's a wonderful answer. I'm sure there's an edible arrangement on its way as we speak. But yeah,
I've installed Ray Face in all of my clinics around the country, and I recommend it to every person who wants to get into full arch dentistry. It's really, in my opinion, the best CBCT on the market with the right field of view.
Thank you. And we're open architecture too. It's like we do have a full suite of our products, but we can plug and play. So if somebody has some other type of equipment, we also, with our open architecture mindset, like to just be able to come in and work well with everything else that the doctor has. They don't have to do a complete overhaul of their office.
Right. Yeah. One of the first questions I ask doctors is, what CBCT do you have, and what's the field of view, and how old is it? Because
Great questions.
Anatomy is destiny. And if you don't see clear anatomy on your CBCT, again, you don't want unpredictability as a reality. You want predictability to not be a worry. And so I tell people that the combination of Ray Face and Ray Scan is the best investment that they can make in their practice if they want to get to the level where they can do full arch cases at ease.
Awesome. Awesome. Yeah, those are my two questions. I was just pretty interested in knowing like how you go about it. So yeah, everybody has the information. Once again, everyone, thank you for taking the time to join us tonight with Dr. Ryan Dunlop, Better Life Dentistry and Full Arch Masters. If you have any questions, please feel free to reach out to us, Ray Scan Academy, or reach out to the Full Arch Masters. If you have any other questions, please feel free to submit them. Dr. Dunlop doesn't mind taking some time to go ahead and answer another question here and there. So again, doctor, thank you so very much. Super interesting. Love the content.
Someone was saying, how do you define success with the CBCT investment? Clinical outcomes, patient experience, financial ROI, technology, leadership. That's a great question. Like I said before, every office should have a CBCT, in my opinion. There's really no excuse for not having a CBCT. Even if you're an endodontist, you should have a CBCT. If you are an orthodontist, it goes without question. Even if you're a pediatric dentist and you're looking for development, wisdom tooth, all of the pediatric science, I think a CBCT makes sense. And for general dentistry, implant dentistry, there's absolutely no excuse for not having one. I diagnose a lot of pathology off of CBCT. I catch periapical radiolucencies, I catch sinus problems, I catch airway issues, I catch growth and development issues. There's no excuse, I think, in a modern dental practice to not have digital panoramic and digital CBCT. It would be very, very strange for me to work in a dental office that didn't have access to that technology.
Great answer. I hope that was serviceable to our
Yeah.
asker here, but yeah.
Okay, good. Well, if you guys have any other questions, I'm always accessible. You can find me online, shoot me a message or an email, and I'm happy to help.
Great. Thank you to you and your staff. Appreciate it. Thank you for staying back.
All right. Have a great night,
Have a
everyone.
great evening.
Thank you, ladies and gentlemen. And we kept it under an hour.